afternoon, everyone. So today we are having the talk by Dr. Karuna on the awareness of anemia and the disorders of platelets. And here I would like to introduce Dr. Karuna Kumar. He is a consultant hematologist and is one of the South India leading hematologists. So he will now talk to us about anemia awareness and screening methods. Thank you.
Sorry. First of all, I'm really sorry for late and making you wait. I was stuck with some emergency patient and I couldn't come. Okay, so today main topic was to create awareness. No? So may I know the audience? So we have few patients, staff and
Patients, staff, and
mix. Yeah. Yeah. Okay. I have to speak louder. So, shall we maintain English or Telugu, ma'am? Which language is? English is fine, okay. So, myself, I'm Dr. Karuna Kumar. I'm consultant hematologist and bone marrow transplant physician. I have a clinic, Dr. KK Hematology Clinic. We have a trust, KK Cancer Care and Support and Foundation. Mainly, we do activities, related to blood cancer and cancers in general. My intention is to create awareness of blood disorders, anemia among schoolgirls and general population, And also, we have just started the trust recently. We are in the process of doing much more activities in future. So part of this activities, my idea is to create awareness on anemia here. So we have a few doctors with us, the gynecologists and also physicians and also patients and staff with us. So initially when Dr. Manasa, we were discussing, we came up about this activity. And usually what I do, I always keep it interactive wherever I go. I interact with students or the target audience. I'll make it, as much useful as possible for the target audience. So I'll keep the same style even today. So either I would like to take some questions from you, and then I'll discuss the, I'll make it a topic and I'll talk important things about it. Shall we do it that way? So because we'll be like discussing to the point and we'll not waste time. We have a limited time now. Okay. So anyone?
Yes.
Yeah, Mans.
What are the early signs of mild anemia which patients can look out for?
Okay. So mild signs of anemia which patients can themselves notice. Okay. So normally our body is very flexible. Our blood is also, even though the normal ranges say hemoglobin starts from 12 grams to 16 grams, in women it is 12 to 15, men it is 13 to 17 approx. Even though the ranges are defined, our body can compensate to an extent. It depends on the activities what you are doing. Suppose say you lead a sedentary life, you don't exercise, you just wake up and you get ready, you go to office, you sit in a desk and you complete your work, come back in a taxi or cab and then again you take rest at home. You are almost leading a sedentary life, right? So to match that lifestyle, even if you have a hemoglobin of 10 grams, you may not notice. 10 grams is anemia, but definition, but you may not have any symptoms. Why? Because of your sedentary lifestyle. So depending on your lifestyle and your activities, you may not pick anemia till it drops to 8 grams in this case, especially when you have a sedentary lifestyle. Suppose those who work and who do exercise and then there is more physical work involved, so you can pick anemia early. So you may start to develop symptoms as early as 11 grams, even 12 grams also. You may wonder, you may surprise, I have few patients with HB of 13-14 grams and they have all symptoms of anemia. What are the symptoms of anemia? weakness, tiredness, fatigue, palpitations like feeling our own heartbeat, and unable to climb stairs, unable to focus in their work, unable to sleep properly, irritable in their behavior, not able to focus. These are all common signs, symptoms of anemia. So I'm talking about those patients, with 13 grams, 14 grams hemoglobin, but all symptoms of anemia, visiting multiple doctors, and doctors finally, what is the diagnosis? Psychiatric disease. This was most of them females. So once they came to me, then I know that there is a entity called iron deficiency with normal hemoglobin. There is a separate entity. So where you need, even MCV looks normal, HB looks normal, you don't even think it's iron deficiency. Once you do iron profile, you will come to know it's a iron deficiency. You treat IV iron with IV iron or oral medications, then patient becomes absolutely fine. Okay. So now coming to the question answer, depends what lifestyle you have, whether you will pick up symptoms early or not. So as I told you, I've listed out the symptoms of anemia. There are some unusual symptoms of anemia which most of you would have experienced if you had anemia. Like unusual the sensation to eat unedible things. I'm not putting properly. It's called phagophagia. You would like to feel to eat things which are not edible. Pica. It's called as pica. Okay. So like sensation to eat chalk pieces often. Okay. And feel the smell of paint and eating more ice cubes. Rice also. Yeah, raw rice. So most often these are all early signs of anemia. For people often think that because you develop anemia because of eating more raw rice or eating chalk pieces or slate pencils. It's the other way around. Because you have iron deficiency, you will have such craving towards those objects. Okay, it's called phagophagia. So pica. So this is the other part of anemia, and then yeah. So most often, people come with tiredness, fatigue, and sometimes, they come with some social issues also. Like this girl, the doctor, the husband will complain, "Sir, my wife is always irritable, always cranky," and sometimes she also feels weakness. So the dominant symptom is the other way around. So even those cases can have iron deficiency, especially school children. They'll not study. People think that they are lazy. They don't have interest in studying books, but actually they have iron deficiency, which can be treated much easier. Okay. So okay. Then any other question? Yeah.
Dr. Karuna, can you just elaborate a simple CBP totally?
Okay. So CBP is the most common test which is asked for in any hospital, any department, like any patient. There's a most common test which is asked for, and that reflects your blood health, to put it simply. It has mainly three parameters. One is hemoglobin, WBC, platelets. Normally here, looking at the report, you can come to the differential diagnosis of many disorders actually. So there are different patients who present with different diseases, right? So looking at a hemogram, you can have single lineage reduction, say anemia alone, isolated anemia or isolated leukopenia, isolated thrombocytopenia, or you can have combinations of cytopenias, bicytopenia or pancytopenia. So each cytopenia has its own differential diagnosis and cause. So more topic relevant to us is anemia. So when you have low hemoglobin, so the different values are defined, like something between 8 to 10 is mild and less than 6 is very severe. So what are the other parameters you should look into when you have a patient as anemia? First you should look is MCV. That's the most important thing. This is a mean corpuscular volume. It describes the cell size or red cell size basically. By simply looking at MCV, you can make a differential diagnosis easily. If MCV is very low, say in 60s or 50s femtoliters, so there's not much difference. There are only three disorders with it. One is iron deficiency. The other one is thalassemia minor. Other one is rare, like lead deficiency or some which we don't see normally. So most common two differential diagnoses: iron deficiency or thalassemia trait. Thalassemia trait, which is often underdiagnosed problem, which should be picked up before, in fact, marriage, but at least before conceiving, or at least in the first visit when the pregnant women come to the hospital, we should be able to pick up thalassemia trait in the mother. So HB can be anywhere between 9 grams to 14 grams if you have a thalassemia trait. It's not like every thalassemia trait will have HB of 9 grams or 10 grams. You can have thalassemia trait even with 14. Normally, you will not see a patient of thalassemia trait with HB less than 8. If it goes beyond less than 8, and if you are suspecting thalassemia, it is more than minor, somewhere intermediate or major. It's not definitely not major. Major usually picked up at the childhood. So usually it can be of intermediate. So remember, thalassemia minor always between 9 to 14 grams anywhere. So first thing you should ask is whether the patient is symptomatic or not. Even clinically, if the patient is not symptomatic at all, able to do all works, especially when you ask for symptoms, as I told you, depending on the lifestyle, if they have sedentary life, they will not have symptoms. Ask for questions, where the exertion is involved actually. When asked specifically, when they exert themselves, is there any symptom? Such patients. When they have symptoms and HB of 10, MCV is low, likely it is iron deficiency. If they don't have any symptoms, even have exertion, normal active lifestyle, then very likely it is a thalassemia minor. So it is about low MCV. When MCV is normal and HB is 8 grams, normally little serious problems come into this category. Again, you have to look into the age. Elderly people, often it can be of marrow disorders. And in children, again, depends on the other cell lineages. So often serious problems related to anemia fall in normocytic category, like say hemolytic anemias and or marrow disorders. High MCV, again, when MCV goes up, normal, again, differential diagnoses are very few. Most common is megaloblastic anemia, B12 deficiency. The other differential diagnoses are myelodysplastic syndrome, aplastic anemia. These are the two differentials where patient will have MCV higher and they have anemia. Okay, so you do B12 levels, and if it's normal, LDH is normal, then there are chances patient can have MDS, depending again age. You don't diagnose MDS in a young kid. Again, you have to look into the age. So MCV helps us a lot in diagnosing many anemias. Sometimes there can be like B12 deficiency and iron deficiency. Your MCV become normal. Iron deficiency brings the MCV down. B12 deficiency, it rises the MCV, then you will get normal setting. See, whenever we have values helps us, but always we should look at the patient symptoms. When the patient walks in, I can diagnose megaloblastic anemia. When the patient opens the door, they develop the classic look of B12 deficiency. They'll have a classic skin texture. This special B12 deficiency, this you'll develop after seeing a lot of patients. Again, ITP patients, we have a look. They have a look. Always they have steroid outside. They have Cushing white. The remaining parameters, ma'am, you want other parameters also like white cell count and platelets. White cell count, multiple differentials are there, depending on the differential count, number of cells, then we have to decide about that. Any other question?
Thrombocytosis, whatever the causes of thrombocytosis.
High platelets. Yeah. Again, thrombocytosis is one of the very common cases I see in my practice. So often the patient comes to you in a panic mode, doctor, I think I have a blood cancer. That is the first thing, patient comes in. Most of them will have anemia. These thrombocytosis cases, often if you have 10 patients, almost 6-7 patients will have parallel anemia with it. The reason being iron deficiency. So iron deficiency somehow pushes. Probably when there is iron deficiency, these RBC, red blood cell size become very low. This microcytic. Sometimes there will be fragments, which can be picked up as platelets. That also can happen.
7 lakhs, 8 lakhs.
Yeah, possible. Normally, iron deficiency alone will not push platelet more than 10 lakhs. But we have seen cases up to 8-9 lakhs. Possible. See, sometimes there can be overlapping problems. There can be some inflammation going on. There can be a recent surgery happen. There can be overlap infection all these things will push additional platelets to higher level. So other than iron deficiency, then you have, as I told you, inflammation and infections and post-surgery and post-splenectomy. These are the 4 other common reasons for high platelets. And leaving this apart, essential thrombocythemia is the one condition. Often seen in young women. Even we have patients, up to 12-year-old girls have had this problem with high platelets. After extensive evaluation, you couldn't find anything else. Here, there is excessive marrow production which leads to thrombocytosis. That we can prove it through genetic mutation called MPN reflex panel. Sometimes you may not pick anything. You will not pick anything except in marrows there will be some changes. So there we have to exclude other causes and then we have to diagnose these disorders, myeloproliferative neoplasm.
But PCV?
Paxil volume is more relevant for us when managing cases of polycythemia vera. So where we target PCV of at least 45. Normally, a PCV, if I'm not wrong, calculation is HB into 3.
By 3. Yeah, PCV by 3.
PCV by 3.
Or HB into 3.
Into 3, yeah.
So I use mainly, to manage polycythemia vera cases where we target PCV of less than 45. Otherwise, I don't use routinely in diagnosis. When cross-check whether the lab report is correct or not, you can use it sometimes. When PCV and HB that doesn't match, then you should repeat the sample. That's
See, normally, whenever we see anemia, it is very low, we refer them to a physician. So is MCV the only criteria by which they'll decide whether they should be sent to a hematologist? What are the criteria when a physician should refer it to you?
Normally, ma'am, what happens in practice, low MCV can be easily managed by a physician, only to refer to a hematologist. We have to get an iron profile and we should do a basic HB electrophoresis. In practice, what happens often, people don't investigate low MCV, they start prescribe iron supplements. And then what happens, patients, either they are not compliant or they don't tolerate oral medicine or they don't come back to a physician again. And they use it, like once in a while they use them, feel better, they stop it, and again the cycle repeats on and on and on and on. And finally, it never improves to normal, they come to me. They think that this problem is bigger and they need a bone marrow examination. So once you...
Managing is little challenging in cases of pregnancy. So when should we decide to give them replacement of injectable?
So again, anemia and pregnancy, again depends on the cause. Often we see iron deficiency anemias. Those are the most common reasons. There, normally what we should do, ideally before conceiving, HB we should try to build up the HB, but not often the case. They come already, once they are in the first trimester already. Then depends the severity of anemia. Mild anemia, because first 3 months we know, usually they don't tolerate oral medicines, we can start oral iron from the 4th month. If the anemia is severe, there is no contraindications to start oral iron therapy from the day 1. Only thing, you should choose a medicine which is easily tolerated, because there are so many preparations.
Which is one you prescribe.
Yeah, your insights on microsomal and liposomal iron. How effective they are.
Usually my practice often I use this ferrous fumarate, ferrous sulfate, glycinate I have not used, but often I use liposomal iron. I see it's more well tolerated in most of the patients, but not like universal. There are patients who don't even tolerate even liposomal iron. But I might be slight biased because we don't keep on changing prescriptions. Once it works, we try to continue the same. I use Livogen, this Ferrone XT also, but
Microsomal iron superior to liposomal in effectiveness.
see, what is most important is taking the iron medication in fasting. It matters much more than the preparation. Take any preparation if taken properly, fasting, before food, and with vitamin C or lemon juice or orange juice, most often it works.
But already most of people have gastritis. Iron causes.
Again, there are 2 sets of people. You see, in practice universally, there is not even a single patient where I don't talk about advising them to take in fasting with lemon. I never miss that in my practice. In my experience, 70% of them will take it. 30% they will not tolerate. Whether you give it after or such cases, what I do, I'll ask them to take at least 2 hours after food.
That is always.
Yeah, in between meals. Correct. At least that will help little bit. Most important is, we should see anemia, as ma'am was saying. See, it's simple iron deficiency. Okay. But actually, proper counseling will take 10 to 15 minutes if you talk with the patient. If you have busy practice, it becomes very difficult for you. So the problem is, because of busy practice, you will not be able to spend that much time with the patient here. Whenever you prescribe iron supplement, you should talk about few things. As I said, how to take it is most important among all. Second thing is how long to take and when they should come exactly for follow-up. And you should tell them what to expect, what problems they can face, and also you should give them hope that this is not the only option. There is other option if that fails. Once you complete this loop of advice, they come back, they follow your advice, and usually you see increments, higher increments.
What's the importance of ferritin levels then?
Okay. So, diagnosing iron deficiency is one of the common tests which we use. So, you see low MCV, low hemoglobin, you suspect iron deficiency. And then often, you ask for iron profile, ferritin. So, what is iron profile? Ferritin. Iron profile has serum iron, it has total iron binding capacity, it has transferrin saturation, these 3 values. A few labs may do ferritin also in the same package. So normally to diagnose iron deficiency anemia, the specific tests are transferrin saturation or ferritin. Either you should demonstrate low ferritin or low transferrin saturation. Without proving these two, even if the patient has low iron levels and normal transferrin saturation and normal ferritin, it's not iron deficiency. It might be of some anemia of chronic disease or inflammation. So either you should be able to prove a low transferrin saturation or low ferritin to diagnose iron deficiency anemia properly. These are specific markers.
Sometimes hemoglobin is normal, but the ferritin is very low.
Those are the cases, where low iron deficiency with normal HB. Those categories. Still we have to treat.
Treat that.
There is a caution here. There is a group called polycythemia again. There we induce iron deficiency in the patients. We want iron levels to stay at lower level. So we take them, we do phlebotomies, and we use medication to create an iron deficiency state in these patients to keep HB around 15 grams.
Is that still practiced? Phlebotomies and all? We used to read when we were students.
See, when the patient comes, just today I've seen a patient, his HB is 26 grams. I've seen earlier, 25 grams was, I thought, the highest I've seen. But recently I had a patient who has 26 grams, absolutely fine, moving around, reddish completely, not much symptoms. So here, what should I do? So to reduce HB, so my target is now 15 grams. So with medications, it will take at least 3 weeks to 1 month for the HB to come down. So initially phlebotomy, we always use phlebotomy as an initial tool to bring down HB faster. There are instances where I have admitted, usually I don't admit such patients if they are not sick. There are instances when symptomatic, you admit and do phlebotomy daily, give fluids, then you continue. So one phlebotomy will bring down HB by 1 gram. 26 grams, already he has donated 3-4 times now, today's HB is 23 grams now. So phlebotomies are definitely useful initially.
How much blood you take out?
350 to 400 ml, depending on the weight.
That can be used for summer.
No, discard it. It has to be discarded. Yeah, it goes to the drain. So patient has to pay the price of the bag, 600 rupees, because it's discarded. There are few cases where extensive workup turns out to be negative. We can't prove it as clonal. Those categories are idiopathic erythrocytosis. I encourage donations in them. I tell them to donate. If proven, complete workup is done. If nothing is proven, such cases they can donate. Yeah.
Sir, one question. How much level of HP will be increased in case of dehydration?
It's a very important question. So often, when the patients come, they come to me with 18 grams. What I do in my practice is I'll tell them to sit outside my OP chamber to drink 500 ml of water, wait for half an hour to 1 hour and repeat the test. Almost 30% of them, the HB becomes normal, 15 grams. So if 18 grams, if you take face value, then you have to investigate JAK2 mutation, all high intestinal, you have to do phlebotomy and all, you label the patient as, once you label them, then go on guess, he will be labeled for life only. Wherever he goes, he will be looked at as polycythemia, even though HB normalizes later. So always, first thing is always repeat the test with proper hydration. Normally with hydration, stable patient walking around, you can expect only up to 1 to 2 grams higher when there is a dehydration. Sick ICU patients, we have seen up to 4 or 5 grams, higher. You give IV, those who come with stroke, especially their initial HB will be 1920. They'll call us for consultation, and we advise them to repeat HB next day, and it falls 3 grams. 3 grams falls in next day, and it comes down to 15. So depending on the clinical scenario, in ICU or OPD, you always hydrate patient first and recheck. But if the patient comes to you with multiple values, there are two kind of scenarios. So already this patient might be following himself in labs, and you might be checking for 3 to 6 months. If three values are there above 18, then it's definitely high HB. If he has only one value with him, then I think it's better to repeat and cross-check and then proceed with investigation.
Recently, one patient, 15 grams of hemoglobin, after correction, it came to 10.
No.
Somehow, it doesn't
The 15,
15 to 10.
No, after what?
After 2 days, 10.
That 15 might be wrong, or 10 should be wrong. Two different labs?
How much fall do we expect with maintenance phase? So you have a day routine. You have hemo concentration.
Normally 2 to 3 grams can come down.
With normal maintenance, 2 to 3 is okay.
Yeah.
Anything less than that?
See, if it's coming down, I think you should wait. It's not like change will not happen in a single day. See, the clinical scenario again, if patient dengue, shock, you should wait for at least 3 to 4 days. And also age, past history, you should look at the past records. Suppose last 3 months back, HB normal, now HB 18 very unusual, no? Polycythemia vera doesn't happen like that. Those values suddenly don't jump suddenly. It will be there since long time. Most often asymptomatic. Yes.
2 questions in general. So there is in people there is a belief that being lean is enemy.
Okay.
Okay. And wherever I go, all the doctors say that until you are fit and active, there is no problem. I'm okay with that. And they say that there is a genetical, there is no issue. When I am lean, my kids are also lean. So. She has been seeing my kids since 50 years.
Okay.
So, can you clarify on that? Is that how, like, is that a stereotyping in the society or really?
No, it's probably the person who told you might have had some biases with him. That is the only answer. He needs some clarity. That is the only thing. What you said is right. Myths actually. Yeah. See, energy, HB equals to energy. As simple as that.
I'm one of those normal lifestyles users, right? Theoretical life, just going to office and
Now do a jog for, at least 3 to 4 kilometers. Then you'll come to know.
I'll try to do that. And my second question is, what are other disorders, blood disorders we can identify unless we go for a blood
Check up. Yeah. So actually, this is a very good question. In medical oncology, there are few cancers which we can pick very early by just some simple screening tests. Do pap smear, you will pick up cervical cancer. Do colonoscopy, you pick colonic cancers, and do thyroid scans or mammographies to prevent breast cancer. Unfortunately, in blood cancers, there is no single test which we can identify early, because blood cancer comes like a storm. 1 month back is fine, and now he has a blood cancer. That's how blood cancer is present. Again, there are 2 types of blood cancers. Acute cancers, there are no warning signs, warning symptoms, no preventive steps or screening tests, nothing like that. Chronic blood cancers like CML, there are few disorders where they can stay inside you and can be asymptomatic. Such tests can be picked up with simple blood tests. You can just do an annual simple health checkup, where you can pick up few blood disorders. You can pick up low HB, you can pick up borderline platelets, you can pick up slightly higher WBC. So chronic blood cancers can be picked up early if you do annual health checkups, but those are very rare disorders when compared to other things, So you need blood checkup based on your health profile and your age. That is enough. No need for special attention towards blood disorders.
I have a patient who's 85 years old. Her WBC count is 2,50,000, 2,20,000.
WBC, ma'am?
Yes.
Okay. But she. Okay.
But that's
So,
why WBC count.
So that's what. So there are few blood cancers. So myth is blood cancer is dangerous and people can't survive. Okay. There are blood cancers where even after diagnosis we don't treat. Not that we can't treat. Not that patient has reached his palliation level life. Not that patient is gonna die soon. They'll be asymptomatic in spite of having leukemias. But there are only few such malignancies. CLL, chronic lymphocytic leukemia. This is the one cancer where patients will remain absolutely asymptomatic even with such high counts. But there is a problem in that. Those patients will have lymphocytosis, say 2 lakh count, almost in the WBC if you take, 80% will be of lymphocytes. All these lymphocytes are dysfunctional. They are not normal. The problem with dysfunctional lymphocytes is they won't mount an immune response to infections. So what it says is these patients are immunodeficient. These patients are at very high risk of infections. They can easily catch infection or pneumonia can take them away. That is a problem. So even though they look asymptomatic, these patients should be counseled properly about infectious precautions and vaccinations. But still no treatment. You observe them, but they should follow these precautions. And one more blood cancer, CML, chronic myeloid leukemia. Even those patients sometimes can be asymptomatic, but CML often progresses. They develop huge spleen, then they'll have abdominal pain, distension, and they can develop complications later. For time being, for temporarily, CML patients can be asymptomatic, but they'll progress. It's always important to define the disease and have a proper counseling. And also low-grade lymphomas, even the patient has lymphoma, blood cancer, they don't have any symptoms, even it is stage 4, asymptomatic, we'll wait. Say like follicular lymphoma, low-grade lymphomas, we don't treat, we just observe them. Because even if treating will harm them more than waiting. Any other questions? I think we've...
So when we are giving this FCMs for treatment of anemia, at what is the cutoff, like less than 6 or more than 6, what do you suggest?
Normally, there are few sets of patients who come to me. Few patients come with HB of 2 grams. And I have surprisingly heard from them that they don't have any symptoms. A few patients are there.
They become chronic.
Chronic and they compensate. And they are more often they are sedentary in kind. And there are patients with 8 grams, they will be very much symptomatic. Again here I decided FCM based on the symptoms rather than the hemoglobin. But anyway, less than 6 grams we always prefer IV iron because they are just compensated. Any one sickness or one disease, one another illness can push them into ICU. So always you try to increase HB as soon as possible. So severe anemias, yes, pericarboxymaltose preferred first option. Sometimes patients they won't accept. They are somehow scared of injections. They feel that something will happen to them. Always patients should be prepared mentally to take IV iron. Otherwise, very difficult for them. They'll anticipate and they'll get the reactions. That's what happens. Sometimes it depends, like they'll become unconscious and so many drama will happen. So counsel them, if they are willing, less than 6 grams, give IV iron first, severe anemias. Anything 7, 8, if you have time, patient is not much symptomatic, you can always choose oral iron first. And again, depends the patient, what the patient wants. Always you discuss with the patient, ask them what they want. Sometimes, because of the schedule, because of they have to go abroad or they have some studies, or they're planning pregnancy, sometimes even though 8 grams, we may have to build the HB faster. Depends what the patient wants and then you have to decide. But as a rule, as severe anemia, always IV iron first. Moderate, mild to moderate, you go with oral iron. Again, we know the set of patients who are not tolerant, oral intolerant. You choose IV iron first.
Yes, I thought very low hemoglobin first blood transfusion, then IV.
Symptomatic. Symptomatic. Failure. Patient failure.
First give blood transfusion.
Yeah, so when they are in, as Prakash saying,
Yeah.
when they are in failure, they don't have any option.
Even
Yeah.
if as low as 3 grams, we can go for IV.
Yeah, sure. Yeah, point. If they're not in failure, because I have patients come to me, few patients know me that I don't give transfusion and I increase HB. That's why they come to me. So such patients, I always counsel transfusion in them. I will document. Patient is not willing for transfusion and they have 3-4 grams. Then you can always choose IVRN there. So it works actually. Within a week, the HB will increase by 3 to 4 grams. Often helps. But again, counseling. You should ask them strict bed rest. They should tell them you should not move out of bed. On that condition, I am going to give IVRN. If you accept, I will give. Because if they feel that doctor will increase IVRN, I will move around. Something happens, then medical issues. Yes.
So in setup with so much of iron deficiencies, should we include ferritin as a basic antenatal checkup or during the profile? Ferritin, only ferritin, around 20 or 24 weeks. So that
It's always ideal because treating anemia early helps them, right? So because again the delivery part, again they lose blood. Again lactation, they need extra iron stores. Always helpful to build stores early.
we can around 20-25 we can 20 to 25 weeks of gestation we can get a ferritin.
Look at the CBP. If they are fine, doing well, MCV is normal. I think no need to do.
That's what I'm saying. Should we? There are the
No. Ferritin is, I think, is not cheaper.
Yes.
Ferritin is not cheaper, I think. It's cost some
That's the reason I'm asking.
2,000 rupees. No.
Include it in a routine checkup.
So, see, go by patient symptoms and CBP.
And this, how about the hemoglobinopathy, the screening for thalassemia at the early stage of pregnancy?
Government should make a policy actually. Now, somewhere they are not doing because I don't think their family members are not affected. Probably.
Some hospital clinics, diagnostic, they are telling extended antenatal profile, they are doing the hemoglobinopathy screening also.
Actually, I think for marriage, during they get married, it should be made mandatory. Don't marry. Or
We are more interested in the
or the first booking, pregnancy.
Yeah, pregnancy,
First-
I agree, you should get it done.
But there is no
First-
point in doing the pregnant woman alone. You need to screen the husband also.
No, at least if there is a trait, it's okay.
If both are traits now,
Yeah, that is, yes.
there is no point in screening the pregnant woman alone. No.
Preconception.
Yeah, that's what you should.
We have to extend the investigation.
When they come,
You'll have a reason to.
Extend the investigation.
in that you can put this profile also. They will get it done then.
HbA2c is mandatory test for all pregnant women.
I think
How
so.
do you
We
treat
should-
pregnancy anemia differently? Because it is dilutional. They usually
Dilutional won't affect them, right? They won't be asymptomatic. We expect 2 grams drop naturally in all women. If they're asymptomatic, then CBP parameters are fine, then no need to worry.
They are ferritin too.
Not required. Again, ferritin MCV slightly drops. See, there again, as Rakesh was asking, sometimes MCV can be normally 80, right? Lower side. You will have some patients with 76 MCV, 75, HB 12 grams. Those patients might have this iron deficiency. There it will be help you to pick iron deficiency. If MCV is normal, HB is fine. I don't think it's. But if MCV is normal, HB is slightly drop in pregnancy, again dilutional. If they asymptomatic, not to do.
So initially preconception was 10. It might come to 8. Then do we give
Preconception 10 means then the problem there, right? Preconception 10 is already she has anemia. Then
She's anemic.
definitely.
So you
Most of the
give
Indian
IV
people,
over
the lower class people are anemic.
Yeah.
So you prefer
pregnancy
IV
versus-
over
First 3 months FCM is contraindicated. We don't give IVF.
No, first 3 months.
Absolutely.
Yeah. So we don't have enough data.
I have seen 2 patients whom first trimester we have transfused and the babies had problems. 2 patients.
Oh, is it? Okay.
One is Khushbu, one is Khushbu.
What
Baby,
problem?
baby went on to ventilator and baby was shifted to Rainbow, Khushbu patient.
How do you know that it is because of that?
That is totally different story.
Two cases, anecdotal. Yeah. No, but why did we give IVRN there?
Ferritin was very low, the MCV was very low. She was having severe anemia of 6 or 7.
Why not
Low
Transfusion, blood transfusion.
Transfusion.
They were not ready for the
Transfusion, huh?
They were
They
not
absolutely refused the transfusion.
No, you have
But
to
they
counsel
agree.
them that you can't give iron injectables, so you have to take transfusion.
So they want mother to be safe and fetus okay. Probably.
We didn't give them the choice.
So in
Maybe, but
severe-
that's correct only. Mother is important.
In severe anemias, what is the role of bone marrow test?
Yeah. See again, ma'am, the reason, the cause of anemia, there are many reasons for anemia. As a nutritional anemias, we never do. Megaloblastic anemias, we never do. Only when you suspect normally more than a single cell lineage deficiency, bicytopenia, pancytopenia, or already adequately treated with iron supplements and B12 supplements, still there is anemia, which is not improving and needing transfusions. Then there is a role of bone marrow. In pediatric age group, we should think of more congenital bone marrow failure disorders, and adults again aplastic anemia and other disorders. Rare disorder like PRCA, this can also be there. So refractory anemia to nutritional supplements, unexplained anemia, or anemia along with other cytopenias, you have to do a bone marrow examination.
Sir, leukocytosis without any complaints. How much count we have to consider it as? And what
Very
is the
common.
next plan of
Yeah.
action?
See, here, look, when a patient has a leukocytosis, high WBC, you should.
In pediatric population.
So you should look at the first differential count. Differential counts are normal, appropriate for the age. Then you see how high the WBC is. Mild abnormalities always can be followed up. No need to act immediately. If HB is fine, mild abnormalities. 25, 30,000 definitely significant. You cannot neglect it. You look whether it's inflammation or infection going on. In pediatric, you are asking, no, specifically. In pediatric age group, 25, 30,000 without infection, definitely there will be hematological problem. There is no doubt. Or they might be receiving some steroids in other form for some other disorder, because steroids always pushes high WBC.
I have a 25,000 leukocyte. I've asked him.
How old is he?
He's 1 year exactly.
1 year. 1 year the ranges differs, no? 1 year old.
I've asked him to repeat again and again, but they're
CRP and normal.
just a normal OPD patient.
reactions can be there.
Leukemia again comes in the background of infections.
The referral count is normal. The referral
H hemoglobin plated is normal. No spleen, no liver. Very unusual.
no liver, no spleen, nothing.
Differential count is normal. Then we need to we can observe. I don't need to worry that.
Sir, one more question. Being a hematologist, we give blood products to babies, right? So we get larger quantity. Maybe 10 ml, 20 ml or something, but we get a larger quantity, like 50 ml, 100 ml of blood. How can we reuse those products once we get from the, we can put in the freezer, or at what temperature, like platelets and
Okay.
We use the same.
This problem we see because SDP, I always make it into 2 packets for my pediatric population.
we need very less, like we need only 20 ml.
That you have
20
to,
ml minimum they will get.
then you need to discuss with the transfusion medicine expert over there, and you have to come up with the personalized plan over there. Normally, SDPs can be made into 2 bags. PRBCs also, we in our blood bank,
PCs we don't need, but FFPs are the ones when the baby is very sick.
we need to have that, volume adjusted bags. That is very difficult to prepare. Probably, these are all personalized things, where you, because the blood transfusion medicines expert is involved, you need to discuss with them and make it. It's purely blood bank related decisions. So that's actually, that will be very useful.
8 hours we can use once.
No, once, once blood is collected, it goes into the blood bank. Once you take out and it comes to the room temperature, you should use it. Once you either you continue the cold chain and you keep it at the, whatever the span it allows. Once you comes out of the cold chain and comes to the room temperature, then you can't go back again. You have to discard or you finish it.
Whatever the product may be.
FFP obviously you can't keep it back. Then you have to discard. Cryo again you can't use. Only possible is blood. Blood sometimes, you start, you don't know what to do, and then you can't go back. You have to discard. Once it reaches room temperature, then gone. Because as soon as they collect blood, it goes to the cold chain. If it comes out, it again breaks because the temperature itself builds the bacterial growth, which is very convenient for bacteria to grow. That's why. And any other doubts?
What is your take on supplementing iron at the start of first menstruation? Many old pediatricians still do that.
Sorry, come on.
First, when the girl becomes
Menstruation and iron supplementation.
So how well nourished the baby is, and it depends.
Yes, they are, but still we are seeing so much of iron deficiency.
That's actually helps. But again, small kids, we have to convince them to take supplements over there. Again, iron,
How many months you usually deliver? 1, 2 months, 3 months?
Very important question. So once you start oral iron, it will take 4 to 5 months to build proper iron stores in our body. First 2 months, you can see only the HB. HB might increase, patient will become asymptomatic and absolutely fine. Then that is not the time we should stop. You should continue the supplement to build stores, which will be stored for later use, because for especially very important for women. So at least 4 to 5 months is the duration. You should continue.
So there are some schools telling that 1 year iron supplementation is needed, 2 years. Do you really think it helps?
See, you can always see what are we trying to achieve here. So you have an anemic patient, you want HB to normalize, right? And you want stores to be filled. Suppose say a patient comes with HB of 8 gram, you start oral iron, and within 3 months HB touches 12 gram. It means that patient is absorbing iron properly and blood is building, right? Then obviously next 2 months of iron tablet is going to increase the stores. Anything more than that will become excess and your body may not take it. Because body, once it's saturated, whatever oral iron is going to be, it will not absorb, it will just discard. One more thing, the few special scenarios, where it can lead to iron overload, but very, very rare.
Usually, ideally 3 months you do a HB before that, even in pediatrics.
Follow up HB, follow up hemoglobin. Follow up hemoglobin I always do in 2 weeks. 2 weeks I call them back because I'll come to know about whether they're tolerating iron or not. No. You need to know how they're tolerating. If you tell 1 month and if they don't tolerate, they won't come to you, they'll go to a different doctor. We should understand whether they're tolerating it or not so that you can make changes. So I always call them in 2 weeks because I expect at least 1 to 2 grams increment in HB and I should know that they are tolerating it well. Then I can change the plan accordingly. Next visit you can call them 3 months. No need to call them again. That's it. Okay, any other questions?
Critical levels of HB levels below 1 year, 1 year to something like that is there.
Okay.
He's asking pediatric cutoffs.
For anemia.
Pediatric cutoffs. for
Critical
anemia.
levels, low levels.
Depending on age.
Again, it changes. So it again severe symptomatic anemia. Symptomatic anemia again depending on their lifestyle and activities. Normally 8 grams. Huh?
1 year age.
Below 1 year.
I didn't get your question. Critical value or severe anemia range?
Below 1 year of age is what he is. Less than 1 year.
Less than 1 year. I'm not
Below
sure.
8 grams, 7, 6.
Below 8
It's somewhere around 78, sir. Yeah. Somewhere.
Because pediatric treatment usually goes different. Sir. We usually are not into too much of IV iron supplements. We are either oral or if it is very severe, we go with blood transfusions. You give
No, I give, IV iron.
in pediatric. Less than 1 year.
See, again, we follow the same, they're tolerating well or not, if they are getting increment or not, they're absorbing iron well or not, they're compliant with oral iron or not.
Most used preparation for pediatric age groups.
Pericarbox maltose is the most common. See, nowadays, I sometimes use this isomaltoside preparation, especially in adults, not in kids. When I need correction of 1.5 gram at single correction, you can do single correction with isomaltoside.
Nowadays we are getting in gel form also. Iron preparations.
I have not used it, sir. There is some oral dissolve, soluble iron. Yeah.
What procedures you do in your clinic? What procedures you do in your clinic?
Here, sir. No, I don't. We don't do much procedure. Bone marrow aspirate biopsy.
You
that
do in
is-
your clinic bone marrow?
Yeah, yeah.
Transfusions also.
No. Clinic is best OP. It's a X. Yashoda Secunderabad. Okay. Any other question? We'll close it.
Join us for lunch.
Lunch, no? Let's see. Okay. Thank you, ma'am. So I thank Director Ma'am Padmavati Ma'am and Medical Superintendent Kameshwari Prasad sir. And Senior Consultant Gynecologist and Surgeon Dr. Naina Singh. Madam,
So, మీరు lunch కి వస్తే I have some
Yeah.
questions.